so many things that I could talk about. And so I do have some slides I put in my little bank here, more to keep me on track, and because you guys probably don't want to be here all day. I thought about kind of what's really going on in the science. And I started years ago actually trying to help my dad. So I was a emergency medicine physician, did that for 30 years, 10 years of that, active duty in the Navy. And there was this concept of being mission ready. But when I got out of the Navy, civilians really didn't have that. We were just kind of humming along. It's like, well, then my dad developed Parkinson's. And so there's really no good medical therapy for Parkinson's. And so I thought, I came from academic medicine. I'll research this. I'll figure this out. And I discovered this whole group of people that think about medicine really more in a forward-looking way. And so I discovered the American Academy of Anti-Aging and ended up doing my first fellowship there. And my good friend Misty at the time, she was a nurse educator at that time. And so I kind of roped her into that, and she got the bug too. And so we did this fellowship. And earlier on, I was still practicing emergency medicine, but I just felt like I was getting all this knowledge that really most people didn't know about, they needed to know about. So we ended up opening up the small little practice, actually just down the road on this side, we're just off the North Side Drive. And 1 or 2 days a week, I just started seeing patients, and that just kind of grew and grew and grew. And then now, we're in a big facility, do this full time, we're as busy as we can be, taking care of as many people as we possibly can. It's the whole, I call this interventional preventive medicine. So there's a lot of things that are very passive medicine, watching things, and vaccines and scans and all that. We're just kind of watching things. We want to back that up, and we want to be healthy and well. One of the premises of functional medicine is we're looking at the body processes. Conventional medicine, many times, just by virtue of our treatments, we're waiting for you to get the disease, and then they're on it. But we want to back that up, and we want to go ahead of that because we can predict that. Now, the concept of longevity. Anybody heard any podcasts or anything talking about living longer, healthier, longer? So we've been doing this for years, and a lot of the same principles I'm going to talk about are related to that. So I tried to cone this down to women, why women are different, why the longevity is different, why some of the perils of longevity in women is different, some of the lifestyle medicine approaches to that, and then one of the cornerstones for that. And actually just last year, another big study came out and looked at the benefits of hormone replacement therapy. About 20 years ago, there was some question about that, or some consternation. There's a large study that's called the Women's Health Initiative. It's a longitudinal study. It's going on for decades. It's sort of akin to the Framingham study you may hear of talking about heart disease. But at that point, there was some question about the benefits of hormone therapy, but it's because they were using synthetic hormones. When they added synthetic hormones in the mix, that's when the change occurred. But even that same study, they've come back out here in recent years and say, no, but when we reanalyze it, and the risk and the overall health risk for mortality from heart disease, from bone loss, from Alzheimer's, that we really need to pay attention again and go back. But the way we do it is a different way that we think mitigates some of the risk that were discovered in the WHO. Okay, so women are different. Women live longer, and so the whole goal is that longer part of life how is it compared to men? As it turns out, there's a paradox there that those women aren't as healthy. They tend to gravitate and become more frail more quickly in the latter years. And there's a number of reasons for that I'll talk about. Also, the other important thing for women is that they're the caretakers. So they're the caretakers for everybody else who gets chronic disease. They're the caretakers multi-generational. So 2/3 of the caretakers are the women. And now, many of us are in the sandwich generation where we're taking care of maybe younger family members or our children that are getting early and early chronic disease, and our elderly parents are getting that. So we've got to pay attention to the women's health, and even though they're living longer, we want to help them live well. So life expectancy, you may have heard women live longer than men. And so the average life expectancy for men is about 73 years, and for women it's 79 years. And so there's a lot of theories of why that is. Well, women do go to the doctor more. They take care of themselves more. They probably drink less and smoke less. They probably don't do silly things and get killed by accident. They also don't kill themselves as often as men do. This gap actually broadened during the pandemic, the COVID pandemic. And so because of all those things, including an increased rise in accidents and suicides in men versus women during that time. But also we think that in many ways women are stronger, partly because they have estrogen. They have stronger immune systems, and we think that's the reason why they actually were more resilient during that time compared to the men. So the reason we die and women die particularly has changed over the years. A century ago, it was infectious disease. Pneumonia, tuberculosis, diarrhea was a killer disease. Now it's chronic disease. It's heart disease, it's stroke, and it's all the cancers combined. So it's really shifted to that when we look at the disease model. But again, the men that live maybe were selective. So the weaker men die earlier and the stronger men live longer, so then they actually appear like they're more physically fit and available to function in life. So another concept I want to share with you is the concept of healthy life expectancy. And so that's actually a public health model that's been studied for many years, and the WHO, the World Health Organization, publishes this data. And so healthy life expectancy. So the healthy life expectancy for women is about 65 years. So I told you actually women live almost to 80, 79 years. So that's a pretty big gap there. That's 14.4 years where we're not as healthy. We've passed the healthy life expectancy. And then for men, they live maybe 62 years of healthy life, and so that makes that difference about 11 years. So they have a shorter time of life, or maybe they're in what we call the decade of decline. So we've got to figure out how to close that gap. And so this is where we speak to, like, our whole practice really. I might want you to live longer. I think longevity is a good goal, but it's your health span. I want your life, your healthy, functional life to get better. And we do what we call morbidity compression. So we're trying to crunch that down at the end of life. So why do we age? Fortunately, there's a whole new science that's sort of been created. It's called geroscience or gerontology. That's totally different from the group of doctors that take care of old people, geriatricians, because their whole goal is to take care of you when you have disease and when you're sick. But the geroscience people are trying to figure out why we age, how to slow down we age. And there's a whole bunch of really popular people with the internet and podcasts. You've probably heard of these people like Mark Hyman and Peter Attia and Dr. Mercola and all those. And so the idea is that we're looking at, let's treat that as a disease. And so the WHO is very close to actually categorizing that, which would really open up a whole lot of research funding for that. But for some probably social political reasons, they didn't designate that yet. But that's really where the science is going, to try to figure out why our cells are breaking down, why we're aging in the first place. So that's the whole idea about this longevity medicine. But we've been doing that all along. This is the lifestyle medicine. It's the principles that we're doing. So we're excited about that. We're getting some more tools. We're getting some more technology. But when we go back to how do we do it, it's the same sort of thing. There may be some newer. They're trying to develop some newer drugs and newer things, but we've kind of known this for a while. But the science just keeps agreeing with us as we go. So keep me on track. So the idea of what's the best way to do it? Do we tick through all the diseases and try to stop each of the disease? Well, that only gets us so far. So that's what we call the disease control model. So it sounds kind of trite, but first, don't die. First, just don't die from things that are stupid. Don't die from accidents. Don't die from infections that you could have avoided. Be healthy in general, and just don't die from that. But then, how do we extend that? And that's getting at this thing called longevity medicine, and how do we get our health span back? The other question comes up, well, I do have some longevity in my family. My great-grandfather lived to be 100. He was born in 1876, and he wanted to see the bicentennial. He wanted to see the country turn to 200, and he swore he was going to live to that. He drove up until his mid-90s. He was still driving a car, taking himself to to church, taking himself to the Masonic Lodge. He was doing all that. And then one day he says, I think I ought not drive. So we think, Grandpa, I think that's a good idea. You're 95. I don't think so. And he just died quietly in his sleep about 6 months after he turned to be 100. He did see the bicentennial. So is that genetic? Yeah, there's some good genes, there, so that helps. But there's a couple of big studies. There's a Scandinavian twin study and another study that looked at ancestry databases. But only about 5 maybe to 20% is genetically related. That means we're in control of 80 to 90% of that. So we can change this. We're not destined to, everybody in my family is obese. Everybody in my family has heart disease. We can change that. So we're not locked into our genetics. So lifestyle medicine. So I'm going to talk about a couple of those principles, and then I'm going to talk something very important in this, the research around longevity and hormone therapy. So the health span diet. And so now it's so easy, we hear all of that, and so sometimes it can be confusing. So eat this, don't eat that, eat it this time, don't eat it that time. Don't eat it all. There's all the different types, but it still keeps coming down to some of the same principles. Eat healthy, eat real food, eat the colors of the rainbow. It has all the antioxidants, food, the phytominerals, the things that we need, the vitamins and minerals that you need to make your body healthy. Eat fish. That's a big part of the Mediterranean diet. Mediterranean diet is the healthiest diet on the planet. We've known that since the 50s. And so that's where all those studies came from. They realized that the people that lived around the Mediterranean Sea, they didn't have heart attacks as much. Why is that? It turns out it is their diet and it's the way they live as well. So that's very important. But we can emulate that. The other enemy of longevity is sugar, and in particular the artificial sugars and things like high fructose corn syrup. It's highly inflammatory, and so it overloads our body. And so that's part of the issues with the current epidemic with diabetes, right? Those two words together, because they do come together. We used to talk about things like heart-healthy alcohol, drink your glasses of red wine. This is what they say. I didn't make this up. Men could have 2 drinks a day. Women should only have 1. That's not my rule. I didn't make that up. But now there's some question about that as far as maybe the heart health, and it's probably the healthy antioxidants in the red wine, but it's the alcohol not good. And now we look at the brain health and issues and the risk of Alzheimer's disease, and there's really no healthy dose of alcohol for the brain now. So especially if you have risk factors, family members, then you should think about that as far as your longevity. Drink water. Obviously, we're a chronically dehydrated society. And one of my favorites is drink coffee. So I'm not just rationalizing, but there's some very good studies about coffee and chocolate, by the way, that are very healthy for you, heart healthy for that. Feeding. So feed when we eat. So eat less. So caloric restriction diets really work. It's especially good if you're a rat. Okay, so those studies have been proven. There's lots of longevity studies, and we can talk. We have some Q&A, but a lot of the trendy things now are actually because of some incredible rat studies done by a guy named Dave Sinclair at Harvard. Then so people always ask me, should I take this supplement? Take this supplement. First, will it hurt you? Is it non-toxic? Fine. Will it help you? It's particularly good if you're a rat, but it may help us as adults. We'll wait and see. So eat less, and then don't eat all the time. So intermittent fasting is probably a healthy way to go. And so by that we mean eat at certain times of the day. Probably the simplest and the healthiest thing for us to do is just don't eat at night. Just don't eat the 12 hours after dinner. Just don't eat. We're healthier, and our brains actually release better growth hormone at sleep if we haven't eaten for 3 hours after our last meal. So just don't eat at night. It lets our gut rest. It lets our inflammation come down. Those people tend to weigh less. They tend to have less body fat as well. One of the other things there's been a lot of interesting research on is, I guess this is kind of a typical American thing. How can I trick it? Not really fast, but make my body think I'm fast. And so somebody actually came up with something called a fasting mimicking diet. And so you can actually pretend you're fasting and trick your body into doing all the healthy things with that. There's a guy named Walter Longo at USC, not South Carolina, but California. That interesting guy, biochemist, and sort of backed into longevity medicine, trying to research this. He is Italian, so a lot of what he talks about for diet is Mediterranean. but they've created this program and they've studied this. Literally, they've actually packaged this. There's a product out there. I'm not advertising the product, but there's a product out there called ProLine that actually comes in a kind of a box, a package, and 5 days a month for 3 months consecutive, and then they track these people, and it lowers their blood pressure, it lowers their cholesterol, it lowers their inflammatory markers, they lose weight, and then even 6 months later, they were still better than they were before. So there's something about that. So part of the chronic disease problem, in this country, and we're spreading it worldwide, is calories, that we're just overeating and we're killing ourselves with calories. And then healthy macro balance, so enough protein, enough good fats, enough carbohydrates in the right kind, and then the other deficit usually is fiber. We're usually fiber deficient population. Activity. Sounds so simple, but 150 minutes of exercise a week, so 30 minutes a day maybe. That decreases overall mortality rates by 25%. Wow, that's fantastic, and that's free. We should do that. And so the studies are very clear. People want to, come up with these fancy drugs, and there's one out there like chemotherapy agents to try to clear your cells so you live longer. But how about exercise 30 minutes a day? So that's easy, low risk. Doing our cardio is important. The other is lift a weight, particularly women, because women lose muscle and bone really very quickly, particularly after menopause. So the women that had the lowest muscle mass, the medical term is called sarcopenia, had a 50% higher death rate than women that were in the upper quartiles of muscle mass. And so, again, so easy, and it's not some expensive drug for you to do. The other premise is sleep. So maybe there's no surprise. So 2/3 of Americans are overweight or obese, and that number's growing. But also, 2/3 of Americans could have, if we ask the right questions, a diagnosable sleep disorder. We ask that. It's so prevalent. Whenever I see someone that comes in and they say, "No, doc, I actually sleep great. I sleep 8 hours a day." It's like, they're uncommon. Or maybe they think they are, but as we get into it, I do get up several times a night. It's like, okay, so that's part of the sleep disorder. So sleep. If you sleep less than 6-7 hours of restful sleep, that's not the time you're in the bed, but this is time of sleep, those people weigh more and they're more risk for having diabetes. If you sleep less than 8 hours, that also increases your risk of getting coronary heart disease. And so that sleep part is so very important. And the sleep hygiene. We're adults. We don't have to be put to bed, but we should pick a bedtime. How many times, the death of me is one more email. I'm ready, I'm tired, I'm going to go to bed, but I'm just going to check things one more time. 45 minutes later, I'm still doing stuff or writing. So go to bed, give yourself a bedtime. Give yourself a nice sleep room. It should be cool and dark and quiet. It should be a place where, you don't do other things in the bed. So the bedroom should be for sleep and sex. When you start inviting other things and people in there, our brain gets confused with that. There's a psychological imprint with that. It's just like, think about it. So you go into the TV room, you think, oh, I wonder what's on TV. You walk through the kitchen, you can't help wonder what's for dinner. You start thinking about food. It's the place where you are. I go into my office immediately, okay, what's my emails? I'm starting to think work. So you confuse that space. That should be your little oasis time in there. Then the other thing is sleep disorders like sleep apnea. It's rampant. So if you have a spouse or a partner or you yourself are snoring and not sleeping good, or poorly controlled hypertension, gaining weight, can't stop, then sometimes it's the sleep. And that's easier and easier to measure now. One of the other easy ways that we actually had a patient recently, we can talk about different tracking devices, but I have this thing called the Oura Ring. Have you heard of this? It's one of the best biometric devices around, and it does measure my sleep. Because being an ER doctor, working shifts, I've had terrible issues for years. But it measures my sleep quality, my heart rate. But now this new edition actually measures your oxygen level. And so I had a patient recently, trouble sleeping. They were trying to figure out their sleep, so they got the Oura Ring, and the Oura Ring told them that their oxygen's dropping severely low at nighttime, and that discovered, because she's not a big person. You think everybody has to have to be obese for that. So that's a good tool to be able to use for you too. Okay, I'm going to switch gears, and so kind of where for women, where do these health risks sort of accelerate? It sort of turns the page around the time of menopause. And so, and this has been studied for decades, and it's kind of exciting. We've seen the pendulum kind of swing back this way in the past several years. So we've looked, and even the WHI study from 20 years ago that sort of scared us off of hormones because of the addition of synthetic progesterone. But they continue the study, and even women, it's kind of counterintuitive even to most doctors, even the women that continued some estrogen therapy actually were healthier and had lower rates of breast cancer. And so it's because probably they were healthier overall. So we really have to change our way of thinking about it. But we've ascribed all along that we need to do things safely, and that synthetic materials and synthetic hormone drugs actually are a different risk set than bioidentical hormones, which match what your body would make normally. So just this is 22 in the Journal of Cancer. Hormone replacement therapy reduced all-cause mortality, no matter what women died for, by 39%. I mean, we kind of knew this from before, but and a lot of that's attributable to protection from cardiovascular risk. So that's really huge. And so it's not something all like latest greatest fancy, unusual, some compound from jellyfish. That's none of that. This is the stuff that we should be doing to correct it. Until menopause, though, heart disease lags in women, so they have less heart disease. It has a delayed onset, but after menopause, cardiovascular disease goes up 2 to 6 times compared to women that are premenopausal. And we think, of course, it's probably related to the protection of estrogen. So if you give hormone, does that do anything different for heart disease? It looked like it lowered mortality by about 32% when they did that. And that's it's a comparison of 23 large studies. They did this, what they call meta-analysis. So they compare as much of the medical literature they know on the topic, and then they say, okay, what's real? What's really happening with that? So that's fantastic, and that's very recent information. And so why is that? So it has something to do with estrogen. And we know that when women have normal hormones or have hormones before, it also seems to modulate cholesterol. So cholesterol is related to cardiovascular disease. We're kind of led to believe it's the disease, but there's all these other things happening in the heart. It's inflammation, it's oxidative stress, it's immune reactivity. But guess what? Hormonal balance actually helps to correct all of those things. But at menopause, when the hormones go down, the bad cholesterol goes up, the LDL cholesterol, the total cholesterol, triglycerides, even this is nasty little cholesterol particle that some people have it genetically called Lp(a). And you can't tell if someone has it just by looking at them, but it's their genetics. And some people, they can look fit and be tiny, but they can have this huge Lp(a). So it looks like it could even help that. And then the good cholesterol, the HDL, and the reason HDL is good, it helps to recycle it, it actually drops. So it's kind of insult to injury. So not only did you let my bad cholesterol go up, but even my protector, it went down. So repeated studies, a Korean study showed us that again and again. Kind of flip through. Overall, even the risk of blood clots, so that was one of the issues in the WHI. It's like, okay, and if you ever took birth control pills and things like that, they said, okay, you can't smoke, and you have an increased risk of blood clots and cancer and all that. But it looked like that replacing bioidentical hormones actually decreased the risk of blood clots even in that group. So instead of going up, went down. All the bad stuff went down, all the good stuff went up, and mortality went down. So we talk about potential risks for that, and so, but because of popular and I guess it's more emotional, more visible is breast cancer in women. Huge problem. 1 in 31 deaths in women is going to be from breast cancer, but 1 in 3 deaths is going to be a heart attack. It's going to be heart disease, and so that's amazing. That's really just kind of overshadows that. So that's basically 1 female cardiac death a month. It's just amazing. And when women get heart disease compared to men, it's actually more deadly for them. They're more likely to die from the initial. They're more likely to have sudden death from the initial one by about a quarter, and then they're more likely to have recurrent fatal heart attack or stroke compared to men. So if they get it, once they get it, it's even more deadly than for the men. So we want to prevent it. So there's some theories about estrogen and how that works. And so estrogen does some good things. It helps the blood vessels actually to be more pliable, increase something called nitric oxide. So you can also increase nitric oxide by exercising, by eating leafy green vegetables, beets, those kind of things. Very, very good for you. And maybe I'm doing that by genetically modifying some genes that keep the blood vessels healthy and stretchy. It's also promoting healthy collagen. So collagen, very important for your bones and your skin and your face and all that, but also your blood vessels. So our cardiovascular system has big collagen tubes, and so it helps to keep it healthy and stretchy so it doesn't pile up with cholesterol clogs. Even lowers blood pressure, especially transdermal estrogen, which is how we usually apply that. It's doing a couple of things. It's relaxing it, but it's also inhibiting the constriction from our sympathetic nervous system, which is related to our stress, which we'll talk about that in a second. Overall heart health, it's just better from multiple different ways. It decreases inflammation. It makes our blood less sticky. So there's so many good things that the natural levels will do for us. But what about drugs? Don't we have drugs to help with that? So they did some head-to-head comparison and look at, okay, what do statins do for us? So statins are those Lipitor, Crestor drugs. Probably at least a third or quarter of you are probably on it. I've been asked to be on it with that. But when we look at mortality, it doesn't seem to really be changing mortality. We know HRT does, hormone replacement therapy, but it doesn't. The female studies looking at statin use, and they're looking at higher dose use over years though, it increased the risk of diabetes by about 25%. But we know once you get diabetes, you actually accelerate your risk of heart disease by 3 to 5-fold. So we're kind of adding one treatment because we're trying to save one, but we may be inducing another. So amazing. Even compared to like taking aspirin or a particular kind of blood pressure medicine, those really didn't have really big changes in that, comparatively. Amazing. And it's all natural. So we know that it may actually even prevent the plaque from sticking to the artery, but also we know that it actually may reduce it. So we may see some reversal. So it could be, some people are suggesting maybe this should be a treatment, so what a great anti-aging that helps the blood vessel to be healthier and younger with that. Which is one of the issues sometimes in the WHI study. So they used older women, higher risk, well past menopause, obese, pre-diabetic, probably good chance they had more chances of having heart disease. And then they gave them some estrogen. So it is possible that they showed earlier on, there may be some remodeling of that. So there's actually a slight increase in events and cardiovascular events at the beginning, but then later it was significantly lower. So we have to be careful. So we're careful and advise people when we're starting and what the risk might be for that, but the longer term risk look fantastic. So that's talking about estrogen. Progesterone is another very important hormone. We always want to balance them. And so that looks like that's one of the issues, certainly with cancer risk, is unfettered estrogen levels. And that's why generally doctors wouldn't want to give just estrogen. They want to match it with some kind of progesterone. Unfortunately, they typically use some synthetic, which actually increases risk. But if we matched it, there's a very large study called the Nurses' Health Study that longitudinal, decade long. They gave back women the progesterone and corrected what we call estrogen dominance. And their follow-up studies showed 10% lower risk of breast cancer. But they use real progesterone, none of the drugs that go along with that. Progesterone for the heart is very good. It naturally relaxes the blood vessels, lowers blood pressure, and it's a natural diuretic effect too, so it helps with water management with that. The other hormone sometimes people forget about in women is testosterone. And so testosterone is very important. It's an anabolic hormone. It helps to build up your tissues. It actually helps to build up bone when we talk about that. In relation to heart disease, the lowest level group of testosterone measured in this large study from 22, recent study, so that they had higher rates of serious cardiovascular events if they had very low testosterone. 2 studies showed that. One study showed, it's called MESA study, again another big study that looks at cardiovascular risk. If testosterone were higher but estrogen was lower, then that actually might be related to slightly increased risk. But if you normalize the estrogen, then they had lower risk. So balance is important. And so as a part of our practice, and we look at that as, Karen, we talk about this all the time. It's like, it's not just the number, it's the balance, because that's so important how they complement each other and how they affect the cell. Testosterone is also very nice to the blood vessel. It helps it to relax and helps to have a healthy lining of the blood vessel wall itself. And it also might help to lower that nasty, sticky little LP(a) cholesterol particle that gets stuck in the right person. The other one is hormone related to heart health is cortisol. And usually we're talking about cortisol in a bad way. It's the stress hormone. It's the one that makes you fat and makes your blood sugar go up and increases your blood pressure, and so in excess. So that's a part of functional medicine. We deal with a lot of stress-related illness. We haven't had a patient yet that doesn't have stress-related illness, and we measure that. We look at cortisol levels and look at the adrenal support. So your adrenal glands are fight or flight. So many times, though, our fight or flight's just clicked in the on position, and we can't turn it off. Hence all the sleep problems, and hence all the other chronic disease. And so we see that some people think, well, that's a functional thing. I'm just stressed. It's in my head, but it turns into physical disease. So that definitely affects that as well. Okay, the heart. Protect the brain. So we live longer. Maybe you survived the heart attack. You didn't have the heart attack. Your blood vessels were good. Then I got to keep my brain healthy. And that might be numerically why, okay, women are living longer than men, so they have a longer time to actually get Alzheimer's. That could be true. But we want to protect the brain. Women are more susceptible for some reason, right? 2/3 of Alzheimer's cases are women. So, but then 2/3 of the caretaker are women too. So who's left to help take care of everybody else, right? So it may be a function of that. But women tend to have more strong immune response. And it could turn into something like autoimmune disease. So autoimmune disease when you attack yourself. So that could be related to that as well. But during the time of COVID, that good immune response probably saved a bunch of people. And again, probably related to estrogen. But in excess, it can cause damage. There can be inflammation that's dysregulated in women. But we also know that estrogen prevents that plaquing in the brain. And then at menopause, they lose that. And so then the brain is already set up to be more active, the immune system's more turned on, there's more inflammation, and there's no protector, so they tend to accumulate plaque in the brain more. Men and women, there's differences. So age is an independent risk factor. Family history, so if you've had a family member with Alzheimer's, then your risk goes up, right? There's another genetic marker that we can measure called ApoE4. ApoE4. We all have ApoEs, 2, 3s, or 4s. But the 4 group, they tend to get Alzheimer's more. And it has probably to do with how the proteins fold in the brain. They also tend to be related to cardiovascular risk and cardiovascular disease. But when we do the studies, I found one recently that even if you have ApoE, if you correct hormonal balance and give estrogen, ApoE group had 54% less Alzheimer's compared to the untreated group, with that. So it's not everybody that, if you go out and get your ApoE checked, not everybody that has ApoE is going to get Alzheimer's. If you have one gene from one parent, your risk goes up about 8 or 9% compared to someone who doesn't have it. If you have 2 genes and both of your parents give that to you, then your risk is about 27%. But that could be cut in half if we do all the things to help control that. So we think we can actually reduce that risk for you. So estrogen helps the brain. It helps all the neurotransmitters do what they're supposed to do, not just in the levels, but in the receptors. So all the, the serotonin, there's so many people take, so many medicines out there for serotonin, but most of our serotonin is actually related to our gut health, by the way. And then balancing the hormones, having the hormones to help with serotonin, dopamine helps us be able to concentrate, focus, and then GABA helps to calm the brain. So all that helps the brain to be more balanced. It protects the brain from damage. It helps the brain with something called neuroplasticity. So it helps the brain to recover and repair itself for sure. It also improves metabolism of the brain and even blood flow. So Alzheimer's, we know now, is not just one type of thing. It has multiple sort of attacks on the brain, and part of it can be microvascular disease. So that cardiovascular disease is clogging the bigger arteries, is clogging the little arteries too, and then there's chronic inflammation around that too. So estrogen by itself helps the brain performance. People learn faster and learn better, and then they remember what they learn better with that. And then also, of course, it's helping the brain with mood and emotion with that too. Definitely improves memory. We talked about that. Progesterone. Progesterone is also protective, maybe not as strong, but it helps to protect the covering of our nerve vessels. And actually looks like it may reverse cognitive decline. So you might say, so your family member, or maybe you're developing some cognitive deficiency, and you say, well, I didn't do hormone therapy for whatever reason, and maybe I'm eligible to do that. If I give a woman back estrogen, you think, well, maybe that'll help heal the brain. That could reverse some of that dementia. The studies haven't really shown that. They haven't really shown that. Possibly improve cognitive function if they replace testosterone, and possibly if we replace progesterone. So it's almost like the horse is out of the barn by that time, that the estrogen is not going to fix that. But balancing the other hormones could be helpful with that. The other hormone that's kind of related to testosterone is called DHEA. So DHEA is an important hormone in the body. So most hormones that we use have to be prescription, or should be prescription. But the FDA is a little confused about things, and they say, well, DHEA can be sold as a food supplement, although it's an active hormone that's in the body. So we want to know what that is and measure levels. But most Alzheimer's patients actually look like have low DHEA. DHEA looks like a mini testosterone, has some good effects with helping with muscle and bone building, but also helps the brain to recover. It acts as a neurotransmitter in the brain. So a minor one, but very important. And then there are a lot of studies looking at this other hormone called pregnenolone, which is kind of the mother hormone. It actually converts into the other ones. I kind of take the approach, I fill in the downstream hormones more than trying to do the pregnenolone at top. So it definitely helps our memory, reduce our risk of dementia. Now the bones, protect your heart, your brain, your bones. It's the third leg of the stool. And so women have more osteoporosis. They lose bone earlier than men do. We know that estrogen plays a role in that. Women have probably about 3 times the rate of osteopenia, which you have bone loss, or osteoporosis when you have a much more severe bone thinning. After the age of 50, osteoporosis occurs 4 times more than the premenopausal. So it just accelerates. Literally the first 6 or 7 years post-menopause, if hormones aren't corrected, there's an accelerated loss of bone, and then it does sort of plane out after that. But there's a significant bone loss that occurs over and over with that. Also, so the bone loss is earlier and faster. They get thinner bones, but then we look at the risk of falls. We look at men and women in comparison. Women have a higher fall rate than men do with that. And it may have to do with testosterone, actually, because there are actually some studies that look at testosterone levels, and that actually is related to your risk of fall. So if you deplete, you're more likely to fall. And if you deplete, you're more likely that you've got bone loss already and that you're osteoporotic, and then you're also more likely to fall. Sort of insult to injury with that. The only, maybe it's not positive, but a difference that's not so bad for females is that men actually have a much higher mortality rate. So if they fall and they break a hip, they're actually much more likely to die, probably twice the risk of mortality than women do with that. Because maybe women are more resilient, they can take it, maybe, yeah. And another recent study, actually last year, they're looking at the comparison of hormone replacement therapy, bone loss, slowing of bone loss, compared to like the drugs, the biphosphonates and different drugs out there. And that far and above, if someone could do hormones, that was much better for the bones. The drugs for bone loss, probably very important if someone's very, very weak and brittle bones, you're trying to do everything to prevent that break with that. But those only slow the loss of bone. They don't build the bone. They don't repair the bone back. But the progesterone and testosterone part, and even the DHEA to some degree, along with the correct nutrition, weight-bearing exercise, those kind of things, can actually rebuild the bone. So when I was in school, we were kind of taught, well, you get to 50, you do a DEXA scan. If they have osteoporosis, you check every couple of years just to see how much worse it's getting. But we see it reverse. We're kind of taught that that's not supposed to happen, but we follow people regularly, and we can actually see that reverse. And it's just good for all. Part of the reason why that's because helping collagen in every other part of your body. You can't see or feel your bones, but you see your face every day. So you say, oh my, I need estrogen. Look at this face. And so whatever motivates people is like, okay, look, you want to have clean skin and be smooth. We can help with that. But I'm looking at the inside. I want to protect your heart, your brain, your bones. I can help your skin, but that's, to me, that's secondary. Definitely helps in every way. In the U.S., 1 in 2 women are going to have osteoporosis after menopause. versus 1 in 4. And so there's more than 2 million fractures annually related to that. Okay, I think I'm going to stop there. I have lots more I have to say. I'm sorry to say. So let's talk a little bit about kind of the approach and things, and so kind of how we do things with that. So of course our practice is it's more of a concierge practice, right? So I don't see 50 people a day. I don't have a waiting room full of people. And when people come and see me at that time, you know, you're the most important person in the office. It's one at a time, because it has to be that way. And this is sort of the integrative medicine and functional medicine model. And we want to look at the whole person. You know, people talk about holistic medicine sometimes gives a different connotation, but I want to look at the whole person. And we'll look at all the things that are going on that's related to you, whether it's stress-related, environmental, past history, exposures, exposures like from toxins, and some of those toxins, you know, could be anesthesia from surgeries, or you know, or where you live, or mold in your house, and all those things, how that affects your overall health and wellness. We want to know nutritional status, hormonal status, your risk factors, your inflammation, your oxidative stress markers. We want to know all those things about you, and then we put that together in a comprehensive plan for the first visit. And we first tell people, it's like, well, your first visit, well, you know, how long do I need to schedule? We say, well, the first visit could be 2 or 3 hours here, and they're like, what am I going to do for 2 or 3 hours at the doctor? You know, I mean, am I waiting for 2 or 3 hours? So, no, actually, you don't wait. You know, I have a lobby, but so that's kind of how we want to know everything and kind of a comprehensive view and take the time to do it. How did we decide how long to be? One of our mentors, Greg Petersburg, he started doing this years and years ago before it had a name, and so he's got to be in his late 70s now. And so, well, how long should we set the appointment times? I said, when is the appointment over? He said, well, the appointment's over when you no longer have any questions. Okay. So it's that kind of stuck with me all these years. So we're using the best science that we know, and some of the science is not brand new, but nobody's like deploying it. Nobody's looking at it, because they'll say, well, I don't know what to do with LP(a), so don't check that. I don't know what to do with cholesterol particle numbers, because there's no drug for that yet. They're trying because they know that correlates more, but there's a whole list of non-drug medicines that we use that can help approach that and look at that from a lifestyle medicine. So all the things we kind of talked about go into detail and give resources and direction to help do that. And then we follow that up. So we're a results driven organization, like many of you probably have been in. We want to know, and so where we can, we get the data to track that and follow that along. And even now we have the opportunity to look at even some newer screening sort of modalities where they're cardiac imaging. So we have some very advanced cardiovascular imaging that we think is going to be sort of like getting a colonoscopy. So one of the ones we use is something called a Clearly Scan. It's an advanced AI technology that actually does an advanced look at coronary artery thickness, and it can actually measure and identify any hidden plaque, and if it's a dangerous plaque or a stable plaque. So things like that, we're really trying to get ahead of the curve, and so primary prevention and not wait till you've already got the disease. But if you have the disease, it looks like some of the things we do are very good at doing some reversal for that to make that better. Okay, I think I'm going to stop and open up the floor for some questions. Yep.
So you actually can do them